Good evening, everyone. My name is Amanda Rodriguez, and I'm the Policy Coordinator for NASW New York. Welcome to the second event of the Joint Town Hall Series with 1199 SEIU and NASW New York. This event is focused on post-COVID-19. Social workers are still essential in healthcare. The chapter extends our gratitude to our attendees, all of you who are here tonight to learn and expand your knowledge and to gain clarity and resources for the work that you do. We appreciate your time and your willingness to engage with us on this vital topic. And please note that this event does not offer CE credits, but we do hope that the content will still provide valuable insights and foster meaningful discussion. We would be nowhere without our partners, and we extend our gratitude towards 1199, Assemblymember Lorinda Hooks from the Assembly District 35, Lauren Walsh, LMSW, Legislative Director for Senator Roxanne Prasad, Chair of the Social Services Committee, and Jennifer Zelnick, MSW, SCD, Professor and Social Welfare Policy Sequence Chair from Touro University, Graduate School of Social Work, for engaging with us on this important issue. We truly appreciate them taking the time to share resources and action items with social workers, and this is the time to take action on these important issues. To ensure a smooth experience, we kindly ask that everyone remain muted while the presenter or guests are speaking. And if you do have any questions or comments, please feel free to submit them in the chat, or if the presenter invites you to unmute, you may ask your question then. Please raise your hand in the case of a question, and a staff member will be monitoring the chat throughout the event to make sure any questions are addressed. We also ask that all attendees respect the NASW anti-harassment policy, which will be shared with you all shortly in the chat. Our goal tonight is to maintain an accountable and respectful environment for everyone and to provide information and resources to those who are seeking it. Additionally, we will be sending any materials and resources discussed today, as well as any info on upcoming opportunities with the chapter, to your email by no later than tomorrow morning. Thank you all again for being with us tonight and for engaging us with our topic. We will first go to our first presenter, Assemblymember Lorinda Hooks. Is she in the room right now? All right, as we wait for the assembly member to get into the chat and join the Zoom, we'll go to our next presenter, Lauren Walsh, LMSW, from Senator Roxanne Prasad's office. Thank you so much for being with us here today, Lauren, and please get started whenever you're ready.
Sure. Thank you so much, Amanda. I'm happy to be here. Good evening, everyone. My name is Lauren Walsh. I am the Legislative Director for Senator Roxanne J. Prasad. She represents the 19th Senate District, which encompasses Southeast Brooklyn and parts of Queens. She, as Amanda mentioned, she is the chair of social services in the Senate, and she has been a leader in the fight to achieve just wages and pay parity for all human services workers for many, many years now. And since we're all here tonight, we know there's so much more to do. So on behalf of the senator, I've been asked to share some insights as to why salaries for social workers and human services workers have been historically low, and to share any opportunities for social workers to act. And I'm happy to be here to do so. So, as you are all probably well aware, many nonprofit human services sector employees, including social workers, have sometimes had to rely on the same social safety nets that they help their clients navigate, right? This is deeply, deeply troubling. We dedicate our lives to and careers to supporting our vulnerable neighbors, and we should not have to struggle to make ends meet. The study that NASW New York State came out with back in 2022, I think really only reinforced what we have kind of known for a while, right? That social workers and human services workers are undervalued despite our extensive education, licensure, and not to mention emotional labor and complex crisis intervention skills, right? So while it is heartening that in recent year budgets we've included a modest cost of living adjustment, now known as a targeted inflationary increase, so whichever you'd like to call it, they've not been enough, right, to keep pace with rising costs. So this is not an accident. This is a result of longstanding policy choices, and frankly, under the previous governor, there had not been a COLA for over 15 years. So the sector has lost ground, right? We continue to face challenges in attracting and retaining workers in healthcare and direct care because we're underpaid. But I'd like to highlight that human services is it's an economic force for New York State, and it needs to be seen as such. We care for the elderly, we care for children, ensuring parents and families can go to work. We're working in reentry programs, schools, hospitals, etc. We need to be seen as the force that we are. Much of the workforce is made up of women and disproportionately women of color. Historically, these professions have been undercompensated and probably viewed as care work or volunteer work, women's work, not as a highly skilled profession deserving of the wages, that we work so hard for. So at the same time, I'd say that many nonprofits are almost entirely dependent on government contracts and reimbursements, and reimbursement rates have failed to keep pace with inflation, workforce needs, and cost of living and services. A major issue is that state contracts need to be evaluated. So when funding systems underpay agencies year after year, who gets that hit, right? We get that burden. We don't see higher wages, we see turnover and burnout. This obviously shows long-term impact to communities. So, we're all here to kind of advocate for higher pay. I do want to highlight that Senator Prasad has been the champion of investing in this workforce. She is the proud sponsor of Bill S3669B, which is calling for equitable human services targeted inflationary increase. That is a mouthful, but also known as the COLA. This year, the Senate One House included a 4% increase for human services programs that are included in Senator Prasad's bill, and I'll speak on that briefly in a second. And 1.3% would go directly to human services workers. I wanted to specifically say that it includes human services programs in the senator's bill because currently there are a lot of human services programs that are left out of any sort of inflationary increase. And some of those are domestic violence programs, independent living centers, New York State supportive housing, and Commission for the Blind programs. So we're hoping that the governor is aligned this year, but we shall see, right? So lastly, I guess I'll say, how can social workers act? You're all here today, which is awesome. And this is part of action, is coming together and organizing and speaking out, making your voices heard. I think, being present and engaged in macro social work and systems change, that is a part of supporting your direct clients. I should also say that we should continue building solidarity across sectors. That means social workers, direct care workers, mental health professionals, labor unions, community advocates. Like we all encompass the entire continuum of care. And so I think sometimes goals get muddled when language and efforts are not consistent. And then finally, I think we should continue to try to change the public narrative around the profession. Human services work and social work is not charity work. It's skilled, um, essential labor that keeps our communities functioning every single day. And so, organizing and being together, uh, to work towards a common goal is really what I think helps best. So I'm happy to take questions if I'm able to answer. I'm also happy to drop my email if you have any questions afterwards.
Please feel free to raise your hand and unmute if you have a question for Lauren or drop it in the chat. Well, we did have some fire emojis dropping in the chat as they completed the Act Now for the temporary inflationary increase. Thank you so much for speaking to that, Lauren. I'll give it one more chance to see if we have any questions before we move on to our next speaker. Speak now or forever hold your peace. All right, so thank you so much, Lauren, for speaking to the value of social work, and it is so important for social workers to hold positions in political office. So thank you so much for the work that you do to fight for pay parity. And we're going to go to our next presenter now. Thank you so much to Assembly Member Lorinda Hooks from the Assembly 35th District for being here today. We truly appreciate your time and willingness to engage with us on this important topic, and thanks so much for speaking to our members today.
Absolutely, absolutely. First, I just want to thank you, Amanda, and NASW New York and 1199 SEIU for bringing us together tonight. Um, it's ironic that we're talking about social work coming from the avenue that I've come before I've come here, which is I was the VP for older adult centers. And before then, I was in benefits and entitlements advocate coordinator for, I can't even remember my last job before that. Oh my goodness. From development to OPWDD. So I worked a lot with different social workers and even not just social workers, case managers, case workers, case assistants, aides, and like myself and being a benefits entitlements coordinator. I think people think that these titles aren't really important titles, right? And so we do get shied away from looking when everyone is talking about different facets of healthcare, that we're not a part of that as well, because we are essential workers, especially in a time of COVID. We've proven that we are, essential workers as well. And I want to be clear why I'm here. I'm not here to tell you what you already know about your own profession. I'm here because the fight for social work pay equity is a labor fight, is a workforce fight, and a community fight. And that's the lane that I work in every day. I love the fact that you talked about Senator Prasad and her bill regarding the COLA, but there are several bills in the Assembly that addresses these issues also that we have to get passed. We have you, let alone myself, Assemblywoman Chantel Jackson, who was a social worker before she became an elected official. She fights really hard for you guys as well every single day. Um, Human services work is definitely it's so it touches my heart so much because I say I could have went into any profession. I could have went into any. My degree is in human services, working with humans, working with people one-on-one. It's so essential to people's lives and livelihood and what we do to help these individuals. I mean, myself during COVID, I've climbed through seniors' windows because they weren't answering the door to try to make sure that they were okay. And one of my older adults wasn't okay. And I was able to get the ambulance and everybody there for him. Family lives away. So we go above and beyond just everyday services because we are their first line of defense, of offense, of everything. And pay equity matters. And I think that the more we put ourselves out there and let them know the essential and vital services that we provide, the more people will seriously understand that we should be paid for that, for what we do. In 2020, we called social workers, home health aides, hospital workers, nursing staff, case managers, essential workers, and every day we clapped at 7 o'clock, right? And then we sent everyone back. We all went back out to work and acted like the bill for that essential designation was already paid. It wasn't, and it still isn't. 1199 has been carrying this fight for healthcare for decades, and they understand something that gets lost a lot in Albany. When you undervalue the workforce, you don't save money. Actually, you add more money. Um, I'm not sure how much time I have, so I'm just gonna, if you want me to keep going, if you don't want me to, but I do want everyone, like in my office, my constituent services person to me matters the most, right? Trinice, that's the one who deals with the everyday constituent that calls and they want their needs met because they're in some type of dire crisis. And to help them is helping to be a part of your community. Where I come from in that line of work, I understand that value that has. To me, it's not my chief of staff. It's not my comms person. It's not my scheduler. It's the person that actually works with the people. And for me, that pay equity is higher than as it's higher than most positions because I under most offices because I understand the value of that position. So the one thing I can tell you that I will always do, I will always fight for you guys because I was there and I understand the magnitude of that. And I understand that we need our COLA and we need our fair pay, our equity of pay. I think when I was there, I think I may have had one COLA and I was doing this for 17 years. I may have two COLAs, you know, and sometimes the COLA doesn't even amount to much, but it's a cost of living increase adjustment. And if that's what we have cost of living adjustments everywhere else, why aren't we getting it as well? So, I say all that to say, I understand this fight wholeheartedly. I stand 100% beside, behind, in front of you guys on this journey.
Thank you so much, Assemblymember Hooks. And I did drop the act now for the TII. Thank you for your work in coming at the Just Pay rally and rallying there for human services workers too. Does anyone in the room have any questions for the Assembly member while we have her? Please drop them in the chat or raise your hand if you would like to unmute. But I do want to just read some of the comments in the chat. Doris said, "You're speaking our language." And Britain said, "There are discrepancies with who does what in human services roles, and often blurred boundaries between social workers, case managers, and peer advocates, although we all work together."
And don't forget case assistant workers as well, because sometimes the case assistant worker is doing the same job as the social worker and they get underpaid as well. So, yeah, it's definitely some blurred lines, some differences, but then that's also how it's written, right? Sometimes entities, organizations will write it in a way for different pay, but the actual write the duties down the same. And then that way it does get confuffled. I've been fighting that with Department for the Aging. Well, I don't know how long. And I'm like, if they're doing the same services, then they should get the same pay. Um, yeah, good question.
Yeah, that's a great answer to that question as well. We'd love to follow up on that after this town hall. But then Kelly, she also has another question. Is social worker pay determined by each hospital regardless of all being 1199? How would this potential pay raise be determined, and how can we be sure that it would happen across all sites?
That question, I'm not quite sure. Um, I would have to get back to you on the full details of that, but I do believe 1199 is out there just advocating for the title lines, period. As far as raises, I can't really answer that question, and I don't want to answer it wrong for something that I don't have really the answer for, but I can get that answer back to Amanda.
Great. Do we have time for like two more?
Yes.
Okay, so we have a question from her name is Lauren. Is there anything we can do to assist with the passing of the act? I'm assuming you're meaning the temporary inflationary increase.
Keep coming, keep coming. I know sometimes people, you guys think that, oh, when you come up, if you don't see a lot of members because we're rushing back and forth, we know that you are there. We know that you're there. They all tell each other 1199 is here. The Carpenters are here. 32BJ is here. We all knows that you guys are here and what you're advocating for. Don't get discouraged because you may not see us because they do have us running a lot. And I get a little discouraged sometimes too, and I can't make it there for someone with that is something strongly I believe in. But what I do know is the fact that you're there, right? And so when we're in conference, we can say they were here. They were here today. This is why they're here. Or we hear you guys shouting out the window sometimes when we're in conference and we're like, who is that? And we'll say who it is and what they're there for. So we do know that you guys are there. And the more you guys come, it just shows like we're like, see, it's still a problem. This is a problem. They're here advocating. It was 100 people. Now it's 500 people. Please keep coming. Keep coming. And also, don't forget, please, whatever you do, I don't, if you're Republican or Democrat, whatever you are, please make sure your member knows because it doesn't matter if the majority, not majority, everybody should be signing on for a COLA increase. So make sure that you guys are meeting with everybody. But yeah, really, keep coming. Don't get discouraged.
Snap to that one. But yeah, and you can also complete the act now in the chat that I just dropped as an immediate way to send a message to your legislators on the TII. And then, so we do have one last question. Toop, toop, toop. Doris Joy asks, just wondering, what do you think social workers on the front lines can do to communicate our necessity in the lives of people, how we help people and save the state and city money?
Keep it simple. When you guys are speaking, sometimes keep it short and simple, right? When you say, listen, like the story I just told. I would come up if I was in front of a microphone or in front of anybody, and I would say, in during COVID, I've done this to save a senior's life, and I should be compensated for that. And you just kind of keep it straight and direct, straight and direct. A lot of time we get lost in the words. And if somebody's like going on and on and on, naturally people tune out. Keep it short, direct, and keep it fiery, right? Keep it like, oh, give them a wow effect. So they can be like, I'm about to curse, sorry. But they could be like, oh, shoot, wow, I didn't know that happened. Or that they do that too. So you got to give it to them so they can remember it. So they can go back and say, listen, you have this person commenting in the windows to save an older person. So it has to be very short and direct. I think that speaks more volume than having like a whole script done. But stay there, tell your story, tell your stories, tell your stories. You don't have to say the people's names. Say the story, tell them this is what I do. This is what my job is. The paperwork they don't want to know about. They don't want to know about that, right? Because that's not going to be the connector. The connector is the people. So always constantly say, this is what my job is. Even if your job is doing a whole bunch of case notes or something. Don't say that. This is my job is making sure this person gets fed. My job is making sure this person has a place to go back home to after the hospital. Things like that, has their Medicaid. Keep saying those things. Those are real life stories. That's what matters most.
Thank you so much, Assembly Member Hooks, and that is amazing advice for the social workers in the room. I am going to drop again a link in the chat for our salary survey. That is a great place for you all to describe what your roles are, what your salaries are in comparison to what your role description is. And that will give us some great insight when we are going in this advocacy to support Just Pay and the coalition we're in for social workers and human service workers. Thank you so much, Lorinda, and we look forward to collaborating with your office more.
Absolutely. When you need me, I'll be outside.
Thank you so much, and thank you for all the work that you're doing, social workers. Next, we have a great treat. We have Jennifer Zelnick from Touro University. She actually couldn't be with us today, but she shared a Zoom recording that describes a research project that was led by 1199 social workers, and it focused on their experiences during COVID-19, and it also frames the workplace challenges in healthcare social work that led this project. So I'm going to go ahead and start Jennifer's presentation.
Hi, everyone. I'm Jennifer Zelnick. I'm the Policy Sequence Chair at Touro University Graduate School of Social Work, and I'm also here in my capacity as a contributor to a recent project involving healthcare social workers from 1199 and NASW to some extent, and looking at the experience during COVID-19. So today I'm going to talk a little bit about framing the topic, of this overall session and of the work we did in terms of thinking about, the situation surrounding healthcare social workers and how we might understand that, particularly vis-a-vis, our ability to organize collectively in a union to put forward our vision. And what is our vision? What is our role? So these are some of the things that I want to talk about. I do have a background in organized labor. I have a doctorate in occupational health and safety, and I worked for many years in healthcare union organizing before becoming a social work faculty. I'm trained as a community organizer in social work as well. So if there are any students watching this and you think about what could my route be in social work, this was my path, and I'm happy to talk to anyone about it. Okay, so let me get started, hopefully sharing a PowerPoint. Okay, so I wanted to start out by saying that this is kind of a frame that I want to put around my comments, and it has to do with the value of care workers, because as healthcare social workers, we have a specific job we're doing, but we're also part of a wider care infrastructure. And I think it's helpful to think about it that way, because some of the vision that social work has of the kind of society we want to live in has to do with prioritizing a caring society versus a society organized around profit or, some of the other things that go on. So this is a triangle that basically looks at, people, public policy, and care workers. And this includes public sector workers, nonprofit workers, to some extent, private sector, workers. But, when we're talking about organized labor, we do tend to think about these sectors because our unionization tends to be divided by which sector are we working in. So with healthcare work here in New York, obviously we have people that work in private nonprofit hospitals, people that work in public hospitals. So that's just worth, thinking about what's the sector you're working in. But, the point I want to make here is that the public good is really, a confluence of these three, right? There is public policy, and hopefully some of us are advocates and we organize around getting good public policy on the books. Then there are the care workers who implement the policy, and sometimes this might be called street level bureaucracy, whatever you want to call it, but this is part of what we do as social workers. We do policy practice, right? You probably heard about that during your education. And then we have people who are, participating in these systems, may, need care for themselves, families, and community, and so on and so forth. So the public good is really created in our vision, through the confluence of these three things. So the point I want to make is that unionized workers actually implement care policies, right? This is something that is part of what unionized workers who work in caring professions do. And I think it's really important because power is needed to implement these policies appropriately. So, for example, some examples are Medicaid and Medicare, all the kind of public health policies which are under attack right now, definitely the VA, the Veterans Administration, any policies we have around disability, elder care, mental health. We work on implementing these policies, and so it's a very important confluence. And so, being union members who are both providers and recipients of care under these policies is important because this gives us additional power, to make sure that policies are implemented as planned, that they are not on the books and gutted so that we can't implement them. The other group that can be important in creating this power, obviously, is the National Association of Social Workers, because we're also a membership organization, and we bring our members together to advocate and to make sure, to the best of our abilities, that that social work has a voice and a seat at the table. So I think this is a great marriage of unionization and a professional organization that supports unionization. It's worth saying that in some places and cases, it's one and the same, right? Sometimes with nurses, you have a confluence of professional organization and, union representation, but that's another discussion for another day. These are some images just of union members standing up for public policy that intersects with healthcare policy as well. I don't have time to tell you about each of those, but these are obviously proud legacy that we're part of. Framing healthcare social work, which I also wanted to just say a couple words about, we have to think about the political economy of our public, social welfare, and healthcare and the nonprofit sectors. So I have a bigger framework of how I like to think about these things, not a lot of time to talk about it, but the fact that we have cutbacks in hospital-based social work, working conditions that suffer from low staffing, high caseloads, and lack of leadership, low union participation, definitely has to do with the way that our sector has been neglected in public policy, and the way that not our sector, meaning the workers, but also the funds that are necessary to do the work that we do socially, and the kinds of contracting practices that happen. So all these things feed into it, and the way that social work is valued economically in the healthcare setting, has led to the shrinking of management structures, which reduces hospital social work. And my understanding is there's somebody else here who's going to talk about that history more specifically. So I just wanted to touch on it lightly. But some of the outcomes of all of this is really a contradiction between social work values and the institutional structures where we work. This comes up all the time in our policy courses, the fact that the policies in our institutions are often working at cross purposes with the services we are trying to deliver. What's that going to mean? What are we going to do in the face of that? And our students often say, well, I'm going to quit. I'm not going to work in a place like that. But guess what? Every place is somewhat like that, because the goals of organizations and their, promises to accountability to either shareholders or the board of directors or whatever are sometimes in direct contradiction to offering the kinds of services that we want to offer that are patient, client, and people-centered versus, profit-centered. So, it's a contradiction, but it's something the labor movement, holds near and dear, and that's a place where this is really well understood. So again, really important to bring this analysis to social workers. The project, I'm just going to say a few words. I know I only have a couple more minutes. But the project came about through leadership of healthcare social workers, particularly Doris, who you see illustrated here. We organized a symposium involving 1199, SEIU, and NASW back in 2021, looking at the role of social workers as essential workers in healthcare given the COVID-19. And during this, we out of this grew a participatory research project where some of the 1199 social workers got together with me, and I did some trainings around qualitative research. We did some focus groups. We did analysis. We did member checking, and we ended up getting involved with a group at UMass Boston for a COVID conference, and we wrote this book chapter, which was part of the aftermath of that conference titled Healthcare Social Workers on the Front Lines of the COVID-19 Pandemic, Cracks, Flaws, and a Vision for Social Healthcare. And you can see the authors there, including many people who are involved today. This was a wonderful experience and like one of the beautiful things that grew out of COVID. And, there were really two focuses that came out in the focus group, and they were very intertwined. The first was what happened in March, April, May of 2020, and just the things people faced in the community agencies and also in the hospitals, but also the Black Lives Matter movement that came out at the same time. And these became really inseparable for social workers. And we thought that that discussion needed to be together. It was, just inseparable. In our paper, we talk about experiences of the social workers in these settings during COVID-19, the impacts on the workforce, what, actually social workers did, because there was a lot of things in regards to supporting coworkers and working out systems and having people understand how to work in this trauma crisis that was going on. Social work brought that direct experience, and it was not recognized as essential. And so, you'll have to read the article to get into this. I don't have time to go through it today, but these were some of the things we focused on. And then we looked at the lessons that we learned and where we could go to advocate for some of these things, making social work visible, low pay, staffing quality, and social work leadership in healthcare. And I think that's part of what this series is about, is trying to develop power to take on and further these issues. So I invite everyone. We have a book chapter to share. Please read it, think about how we can use it, maybe build on it. What else can we do? For all of that, these are some of the beautiful social workers protesting outside the hospital in 2020, I believe, for, the Black Lives Matter and Breonna Taylor and George Floyd. Again, Doris can maybe tell you about where these drawings come from. I don't have time, but they're absolutely amazing. Visualization that bring sort of the emotional content about what social workers are trying to convey, what unionized social workers were trying to convey at this time. So I just wanted to thank, obviously, my employer, Toro College, the UMass Boston Labor Resource Center helped us with the chapter, 1199 SEIU, National Association of Social Workers. Actually, this Local 371, organizes our social workers at the municipal level in New York City. And this was actually from a different presentation I did that included them, but I'll leave them up there anyway. We love Anthony Wells and all of our social work colleagues from Local 371, and then finally the co-authors. So again, I really regret that I can't be here and be part of this discussion, but please feel free to involve me in any way in the future, and I hope it's a really meaningful day. I know it will be.
All right. So with that, I'll stop sharing my screen. So that project was largely led by the New York City chapter, as we can tell. Of course, the work we are furthering today focuses on the whole state and the city as you complete the salary survey that we've dropped in the chat to continue this study. And so now we'll go into the next portion of our event. We're actually going to have a panel of social workers that are working in hospitals that were organized through 1199. So as we go into the next portion, I'm going to go question by question. Each social worker has chosen a question that they will answer. And so first I will go with Allison Brockington. So Allison, I'm going to ask your question here. Have you seen your role blur with nurse coordinators or other care management staff? And what does that look like in practice? And how does it affect your ability to do meaningful social work? So, Allison, if you're in the room, please unmute
Yes.
and answer the question.
Yes. Hi, good evening, everyone. I've definitely seen my role blur as a hospital social worker. Um, Often we're compared to other disciplines. We're working with nurse coordinators, we're working with care managers, discharge planners, assistants, and often we're reduced to more daily task-driven work. So whether that's more, scheduling transportation, whether that's coordinating services, whether that's more discharge planning, like I said, and even those, these tasks are important, but it doesn't really reflect the full scope of what social work is or what we do in terms of clinical social work. You know, what makes social work different compared to other disciplines is that we're taught to look at everything. We're taught to look at things from the micro, meso, and macro, systems level. And we look beyond, especially in hospital care systems, beyond a disease model. So we're looking at environment, we're looking at trauma and family systems and structural barriers, social determinants of health. We don't just look at the disease of why the person comes into the hospital. We're looking at the root cause. We try to identify those things, and I think once again what differentiates social workers from other positions is that, for example, if a patient comes in 5 times in 1 month to a hospital, you know a doctor might think that the patient is just, non-compliant, whereas a social worker, we're going to try to ask those harder questions. We're going to ask, you know is there any mental health crisis? Is there any abuse in the home? Is the patient safe? Can the patient afford their medications? And once again, some patients come into hospitals or use organizations because sometimes it just feels safer than, being at home. And once again, this type of work highlights what social workers actually do. We do crisis intervention, psychosocial assessments, safety planning, trauma-informed care. We help them navigate complex systems, and we teach advocacy. And even though it seems like from the outside, some of the things we do are just tasks, but we actually use our clinical judgment when we do these things. A lot of times, once again, we have this problem with role blurring because organizations, they use us more for quantity metrics. And, as previous speakers have said, we have qualitative work, and even though that quantitative is important, but just equating social work to more task-driven duties reduce our clinical aspect, and it dilutes our role.
Thank you so much, Allison. That was incredibly insightful about your everyday work on the ground and the value social workers bring. Now we're going to go to Bria Hope. Bria, how would you describe the gap between what social workers are paid and what nurses or coordinators in similar roles are paid at your institution? How does that disparity affect morale?
Okay, so before I answer this question, I just want to say what facility I work at. I work at New York Presbyterian Hospital as a medical social worker. So, this is quite the biggest issues feel like we have in our hospital. In New York Presbyterian Hospital is the lowest so paid. As a first year social worker, I was getting paid just about like $74,000, and compared to a first year nurse case manager, they would get a significant higher pay, close to about like 90 to about 100K thousand dollars, just being their first experience. So at first it's just very, as like when you come into the field, that's very disheartening that, they say that hospital social workers are the highest paying in the field for social work, and then to the fact that I'm getting paid that low for the amount of work I do. And also for the case managers, because in my hospital they use them interchangeably. Like a case coordinator manager can cover a social worker, and vice versa. A social worker can cover a case manager. So now I'm reading the comments as well, as my colleague Irene said, it's about 120 starting salary now. And it's just like as the cost of living goes up, social like the social work salary hasn't been increasing. The case manager salaries have been increasing, the doctor salaries have been increasing, but social work for some reason still the salary does not increase. It's pretty stagnant. So it's heartening, and it affects your role when you're like we always advocate, as social workers, we're always advocating for everyone else in our field. We advocate, even our case managers, we assist. Like, I know in my personal experience, a lot of my case managers look up to me for shelter placements, for psych patients. They're kind of afraid of psych patients. They don't want to interact with psych patients. And then you have, and it's kind of disheartening, it's like, well, they get paid so much to do the same work I'm doing, but yet I'm assisting you with this psych patient. I'm assisting you with this shelter placement. I'm the one providing my resources, you know? And then that affects, because like you're getting paid more than me, but I'm the one doing the bulk of
You
the
said
work.
her mother's here for dinner the weekend? You guys doing something for Mother's Day? Oh, they're done. Turn it off. Sure.
I'm
Oh,
not
you're
sure.
not doing anything for Mother's Day? She's here for.
Sorry, carry on. I was able to mute them.
Yeah. So it's very disheartening because as a social worker, you're always going to like, unfortunately, it's true what they say. Like we always put everyone else above ourselves, you know. We get low recognition from my hospital. And there's examples where really recently my colleague, she was going up the clinical ladder and she got paid more, but there's no clinical ladder at my hospital. They've been saying they've been working on it for years now, but there's been no clinical ladder. There's no way to move forward, you know. And as I came into like, I was cautious when I first applied for this job because the director of the social work department is a case manager. You know, a lot of the inpatient management are case managers, you know. So like if I even wanted to move up the field, even if I wanted to be like a manager, how would I get there? There's no path, you know. It's just like the only reason I get paid more is because of my union. You know, my union's the one advocating. The hospital doesn't advocate for pay more. There's no pathway up, and that affects your work because you feel stagnant, you know, you feel like you don't have a way to build up to increase your salary. Like a lot of the times you always want more like self-care, more to take care of yourself. You need money, you know, and that's the reality of the situation. And it's just a straight line. It's always consistent with the salaries. There's not enough money for us. There's not enough recognition for us. And that does affect the workload. We get burnt out easier because we're seeing our case manager colleagues get paid more, get promoted more, get more money, and we haven't got the recognition or as well as the pay is for the things we do, the value of our work.
Thank you so much, Brian. And I'm sure that your frustration reflects a lot of social workers' feelings towards seeing other professions being paid more for doing similar work. And so thank you so much for expressing that. And we hope that the launch of our salary survey can help to identify those disparities again, just to refresh everyone's minds that this is a consistent issue that we really need to address, especially as there's a mental health crisis in our state and the demand for social workers is higher than ever. So next we'll go to Irene Sprung. Irene, do you feel your compensation reflects the skill level, emotional labor, and outcomes your work produces for the hospital system? Why or why not?
So I spent some time organizing my thoughts, and it's definitely going to build on and touch on things that the previous two um, people, well, everybody before me already said. And I built in a little bit of history as well about how our department has evolved to what it is today. So I'm also at New York Presbyterian Hospital. I work in the Children's Hospital in the newborn intensive care, and I have been here for 38 years. Um, since you asked in the survey salary, I'll say that when I started here, I was making $28,000 in 1988. So um, I knew when I completed my master's degree that social work, you know, I didn't have this expectation of making a ton of money. You know, that's not why we go into it, but we do deserve and expect a living wage. I knew that other than private practice, that the best pay I was going to find was going to be in a hospital job. That doesn't mean that it's great pay, but it is the best in the field. So our hospital has the second oldest social work department in the country. Mass General was the first in 1906. to hire social workers to address the social and emotional factors affecting patient health. And Presbyterian in Bellevue in Manhattan followed soon after. So when I started in 1988, as I said, the social workers handled all aspects of the discharge planning. We did our psychosocial assessments. We, looked at the patient in their environment and what was going on. We worked with the medical team on the discharge plan. We ordered supplies and equipment. We got insurance authorizations. We did all the things and provided emotional support throughout the admission and up until discharge. We planned and coordinated all of the details with all the agencies in the community, with the family members. We made sure everybody learned how to do the care of the patients who were more complex, and supported the family throughout the whole admission until discharge process. Our clinical training came into play. Sometimes, we always said, and I know Ruth is on this phone call, but I always thought about Ruthie going into a family, talking about going into a family, even for a quick interaction, say to make a home care referral. And while you're filling out the referral for the VNS, you're doing this little support thing, that the family doesn't even realize what they're getting, but you're bringing added value to the patient. You're not just making a referral for a visiting nurse. Shout out to Ruth Massey. So let's see. So for years, when the hospital talked about bringing on nurse case managers, the argument from the social work directors, who at that time were actually social workers, and all the managers were actually social workers, and we were a social work department. The argument to administration was just that, well, social workers are cheaper. So why would you want to bring on nurses who are going to cost you more money when the social workers are already doing the job? And that worked for a time, but I think eventually the hospital kind of gave in to the pressure and the trend in the country to bring in nurse case managers. So that brings us to 2014, when this Making Care Better model was introduced, and a VP was hired who was a nurse. And slowly we saw kind of some evolutions of, well, no, it was after she got hired, sorry, in 2014. So well, what we saw before 2014 was that the social work directors were one by one were phased out and replaced with nurses. So now we're reporting to nurses instead of social workers. We had been for years asking for more social work positions, and we were always told it wasn't in the budget. We didn't have funding for more social workers. But suddenly our department doubled in size with nurses being hired. And it didn't make sense to any of us. We didn't have the money, but apparently discharge planning is a valued service when it's done by nurses, more valued than when done by social work. So the Making Care Better model involved hiring these nurse care managers who took on parts of our role. And initially it was more like we were going to keep the clinical parts of our role, the psychosocial support, and we were going to be freed up to do that part of our role, while the care managers were going to do the simple home care referrals and, do like nursing assessments, not biopsychosocial assessments, but nursing assessments, because that's what patients really needed, was medically understanding what they needed when they go home, not really understanding the added value that the social workers with our master's degree bring to the bedside. These nurses came from utilization or from bedside practice, and they did not know how to do discharge planning. They had to learn it from us. So even though we weren't medically trained, we worked with our teams closely. We learned, we became experts in our patient populations, whatever that was, whether it was oncology or neurology or pediatrics. So now we're in this position of teaching what we've been doing to nurses who are going to then take over parts of our job and be paid more for doing that. I said all this. So when we when we confronted the vice president who was brought in to enact this model and questioned why, if we were supposed to partner and do this work together, why were we being paid less? And her answer was extremely unsatisfactory. It was just, Well, you guys went into social work and social workers get paid less. Like my daughter, who's a teacher, she just knew she was going to be paid less. So that while that may be true, that's not in the situation where they brought in nurses doing our same jobs. And now at this point, as Bria had said, the nurse case managers and social workers in inpatient are largely doing the same role, assigned to do the same role, though they do it differently. Yeah, it's sexist. It's a million different things. Social workers just get paid less. It's that's not the answer. Um, so we don't have a problem working hard and caring for patients. The social workers we always said the social workers, we put our heart and soul into this. We work until the work is done. The care managers clock out when their time comes. And for all that, pouring our heart into things and really caring about what happens to the patients down to the last detail, we are certainly not compensated. Our compensation does not in any way reflect our skill level. I partner with my care manager. My partner care manager is had 2 years at the bedside in my unit and makes more money than I do after working here for 38 years. So no, I do not feel that my compensation reflects my skill level, my emotional labor, and the outcomes that my work produces for this hospital.
Thank you, Irene, and for sharing your experience as such a well-experienced social worker in the field for so long. We truly appreciate that perspective. And on the next question, this is for Maddie Gartenstein. Compassion and fatigue and secondary trauma are real risks in this work, which is a little bit of what Irene just touched on. What does your institution do, if anything, to support your mental health and well-being on the job?
Hi, everyone. Maddie, my name is different on the Zoom. Apologies. I just want to give a shout out to everyone who's spoken before me, and I love how all of the stuff we're talking about is all overlapping, right? And I think everything that has been said before me can also go towards answering this question. So I'm at Montefiore Medical Center. I'm at the Moses campus in the Bronx on 210th Street. Um, I'm an inpatient med surge and overflow floor, and I'm additionally working with residents. We're one of the three teaching floors. So as was said in the chat, the I'm the main person throughout the patient's admission. The residents are changing every 2 weeks. Our attendings are changing every week. The nurses are changing every day. We're the main, as the social workers, are the main face of the institution throughout an entire admission, whether it's a day. And I've had patients who are incredibly complex who have been sitting in their hospital beds for 2 years that I've gotten to know for 2 years and plus. And I think we've all had that experience. But this question is hard, not because the answer is hard, but because the answer is nothing. And that's really, really disheartening and frustrating, um, given the amount of work that we all do, no matter what department, no matter what hospital. Um, One of my supervisors once told us, a group of us, how you take care of yourself is not our responsibility. And something that's happened, our hospital, I can't speak for every hospital, but my hospital's team, the inpatient side, has 26 social workers because we have 3 towers, multiple floors, like it's a giant institution, right? Um, in the span of a year, 12 people have left the job. Our turnover rate is so much that we are losing one person a month minimally. And I have met some of my closest and best friends in this job. I think those of us on the ground are always supporting each other and holding each other up, and we're the ones conferencing about how to best take care of patients and how to best support the patients and how to best support each other. Because if we're not supported, we can't support our patients. There have been days I've gone in and I've just been done emotionally, and I'm not giving my best work on those days. Um, and so we all work to lift each other up on the ground. But, in terms of the institution, in terms of our supervisors, in terms of the bosses, like There's nothing. We do mandate in our contract, we get 1 hour of an unpaid lunch break. We get two 15s. I am someone, and I also train people. I am someone who is very firm that I take my hour lunch and I take my two 15s. And if that means I'm staying overtime, I'm staying overtime because that's what needed for the work to get done. But not everyone is like that. A lot of our team is working through their lunches. They're working through their two 15s. Um, and our patients are going through the worst days of their lives, right? I think last week I have a man, a houseless veteran with some severe addiction and mental health issues who's just lost his entire life, right? And lost all mobility and lost his entire well-being. So I've been emotionally supporting him at the same time supporting a family whose beloved mother is dying and getting them to hospice while also working through the grief process with them, right? While also working with an autistic client who's nonverbal, and how do you make sure that the patient is the priority but also can't communicate with them, right? But how do you then work to be discharging your simple patients because the management is sitting there saying, get people out, we need more beds, we need more beds. But you want to be able to spend time with these people who are going through these crises, right? And then you're going back and you're writing notes. Um, and then you come home and you're exhausted. You're exhausted, and it's to be able to sit one-on-one with these patients is the most wonderful thing on the planet. And it's also incredibly draining. Um, and disheartening to be in a position where to do my job well, there are sacrifices personally that have to be made. I'm very lucky to be in a position where I prioritize getting my own outside support through therapy. Not all of my colleagues are in that position. They've got families to take care of. They've got parents to take care of. They've got kids. I don't have that. So I have the ability, I have the time. Um, And then the last thing I'll say is we I work in an environment where we do have patients that get aggressive, they get mean, they're, spewing racial slurs, they're spewing like I've been sexually harassed on the job, which unfortunately I am not the only one. And usually my management's answer is not what do you need? It's what did the patient want that made them do that? Right. And to be in a place of protecting and supporting the most vulnerable, it sometimes feels like we're also the most vulnerable, and no one is like, hey, how can we make sure that these people are okay? I'm gonna get off my soapbox now. I'm sure I'm not saying anything any of you don't know. So thank you.
Thank you so much, Maddie. And it's so true. It's so important to take care of yourselves as you all experience burnout with dealing with personal issues and also the heavy emotional load of the job. So thank you so much, Maddie, for explaining a little bit what you go through. Going on to our next question, and if we could all try to keep our next responses about 2 to 3 minutes so we make sure we leave some time for discussion at the end. The next question is for Patrice Hetzmeyer. Can you please share an example of what happens when there aren't enough social workers or when a patient is discharged without adequate social work support? What does an unsafe discharge actually look like?
Hi, good evening, everyone. Uh, to answer it the best as possible is to pretty much say the patient returns to the hospital whenever we have an unsafe discharge. Prayerfully and thankfully, none of them get hurt in their return to the hospital. But for the most part, to start the question, the first part of the question is, as everyone has expressed, because our lines are so blurred, we're often sometimes they can utilize case managers or care coordinators to do the work of social work, which they consider to be more task oriented as opposed to actual social work, which is addressing the issues of why the patients are coming into the hospital from a social perspective. Uh, the other part is you don't have adequate time to spend with the patients to take care of them, to do them. So patients are discharged without their actual needs being met. So, they've addressed, okay, they have a fever, so the fever is addressed. Um, you send them to a shelter, so you think that's addressing their unhoused situation. But there are other factors that are impacting housing, that's impacting their health, why they have the fever, could be also related to social factors. That's not being addressed because we don't have sufficient time to deal with actual patients. Like the first, Alyssa said, most of the things that they're asking us to do is not really on a clinical perspective, it's more task oriented. Clicking the boxes to make sure the assessments are done. Okay, giving a referral to a nursing home that gets rid of the patients in their mind and also meets their metrics, which doesn't deal with the issues of how they got the need to have rehab, why they weren't getting the services in the community, what was impacting their family, and who, if they do have family, how do we, support them? So all of these things are difficult to address when you have a 40 units of patients when you're the only social worker handling them. The difference between, because I worked at Presbyterian before, as the other social workers have talked, there's a split in workflow, but here at Northwell, where I'm at now, it's more of all social factors are dealt with the social worker. So the social worker will have, 40, 50 patients by themselves. And there's no real way to address any clinical need of a patient with you're the only person. So those are the things that really impact patient care and safety, which they don't utilize as a safety mechanism here or in any of the hospitals. It's more along the lines of, okay, they came in for this health issue. They should only be here 3 days. So everyone should get them out within those 3 days or 4 days. Not really dealing with, and then they come back again and they go, okay, it's still the same thing. So nothing is ever really fully addressed as from a social work perspective because it's all focused on meeting a metric and not patient care.
Thank you so much, Patrice, for highlighting what happens when social workers are not doing their job to their full capacity as they're dealing with clients. And the next question here is for Maddie Gartenstein. What would fair compensation and safe staffing ratios actually mean for your work and for your patients?
The patients would get the care they need. The team would have a more present and fulfilling social worker. And I think everyone, staff and patients alike, would be safe.
Thank you for that, Maddie. And that does follow up well to Patrice's information about what happens when social workers are not fully staffed and able to deal with clients. And then this next question is for Irene Sprung. What do you want policymakers and hospital administrators to understand about the cost of underinvesting in social workers, both to the healthcare system and to the communities you serve?
I'll try to be more brief than I was the last time. So I think that I know that the pandemic really brought out the importance of mental health support. And there's been so much more openness about people needing therapy, wanting therapy, going to therapy, and less stigma on that. I've seen more and more people either start private practice as a side hustle or leave the hospital to do private practice. Even in my professional organizations nationally, I've seen more private practitioners participate in the conferences. It's just much more out there in the open, and with it being offered over Zoom, it's more accessible. This dovetails with the other question I answered with what everybody else has been saying, but there's a general view that it's acceptable to pay a social worker less than a nurse, even when the social worker has a master's degree and the nurse has a bachelor's degree. That kind of difference makes more sense when the nurse is at the bedside doing really hard physical work with sick patients. But when a nurse's role looks like a social worker's role in terms of doing discharge planning and assessments, then no, it's not okay. And they lack the skill set for the mental health support that we have, and we kind of just give that for free, which is not okay. I said that already, sorry. If people are not functioning at their best, then everything else in their lives is more fragile and it's going to fall apart. So if they're having a health crisis and they had a pre-existing mental health issue, whether it's just, anxiety or depression or OCD or just sort of, functioning people with mental health issues, they're going to become more fragile. They're going to be less successful in dealing with a health crisis. And maybe they're not getting therapy, but, that might be something that we would identify as an issue, not just say, you need these meds, you need this supply, and this prescription, and let's go, you're done, you're good. We might recognize that, oh, have you talked to a therapist about all you're going through, and connect them to a therapist. There's also this tendency to see patients with obvious social issues like homelessness and acute mental illness, substance abuse as the primary population that's in need of social work services. But yes, that's obviously important, and we obviously do that. But it's also these high functioning, professionals or regular people with jobs who suddenly find themselves with a new diagnosis that they also need support. And they often get brushed off by the medical team as, oh, they're coping well, they're married, their adult children are around, they have a lot of support, and not to worry about that. But we, again, as someone else said earlier, are going to ask the harder questions. And are they really coping better? Are they just putting on a face? Often they say, I have to be strong for my wife. I have to be strong for my kids. I have to be, people feel like they have to be strong even if they're the patient. So these patients and their families deserve the opportunity to be vulnerable, to speak about what's difficult for them during their health crisis, to fall apart, to cry, to worry about their spouse, their parent, their child, their family. This is what social workers do while we're in the room saying, oh, what's your insurance? And I'm going to refer you to this agency for this item that you need for your health care. I don't know if all the hospitals have it, but at our hospital, there's this ability in Epic to go in and click some boxes according to what the social determinants of health have been identified in the patient's zip code, and it spits out a list of resources. And this gets attached to the after visit summary, but that doesn't replace a social work assessment. They hand these lists to people, and I think probably most people don't ever even look at that, or if they look at it, they may not ever do anything with it, as opposed to the social workers who really explore which of the agencies, whether on that list or other agencies, which agencies are going to be a good match for that patient. And we will talk to the patient, we will make the referral. We will not just hand them a list. So I want policymakers and hospital administrators to understand that including social workers as a standard part of medical care is not only humane, it is cost effective. When hospitals invest in social work services and measure their impact on readmissions and patient outcomes, they will see that social workers help reduce long-term costs while improving patient care and decreasing readmissions.
Thank you so much, Irene. And it's so important to advocate for yourselves in order to best serve your patients. And so we have two more questions here, and then we're going to go into the discussion portion for the rest of the event. This next question is for Stephanie Flam. What role should unions like 1199 SEIU play in advancing pay equity and safe staffing for social workers and NASW New York? And where do you see the limits of what collective bargaining alone can achieve without parallel legislative action?
Hi, I am a social worker at Mount Sinai West. Uh, I think the biggest thing is that the union has collective bargaining action. And this is something that I try to tell my members when they're thinking about leaving to go to non-union sites at other hospitals, is that like we've been able to fight, even though there is such we're so underpaid. There has been like such a big raise increase in my own salary since starting at Mount Sinai. And that's because of collective bargaining. Like I never could have individually bargained for the amount of money that I have now. And I think that the Pro Tech Council that 1199 has, and the like monthly social work committee meetings that we're having, we get to have a lot more conversations about pay between sites, and different pay differentials. And so I think it creates this wider net where we can all argue for the same thing together. We have, in terms of like safe staffing, we have the ability to codify safe staffing into our collective bargaining agreement. But there are obviously a lot of limitations. I think the one that's like the most pertinent right now is all of the Medicaid cuts. And I think especially looking at the NASW-NY strike and how that all shook out, it's like you can ask for what you think you deserve, but the hospital and the hospital systems are ultimately going to say, like, we only have so much money, even if the way that they're choosing to do salaries is not in agreement with the unions. But they'll say, like, we only have so much funding to work with. And so we need legislators to prioritize funding for healthcare so that we can get um, better pay equity. And then, as like Brian had said earlier, the funding across the profession is generally so low that hospitals are already paying more than what you would get in other um, sectors of the profession. So it feels like they don't really have to compete with other social work jobs because they're already paying more. So we need the entire profession across, like, we need the entire social work profession to be taken more seriously and to have higher pay, and that is bigger than any one union can get. It needs to be us and our legislators taking the profession more seriously. And then I think, like, the biggest thing, and the thing that I struggle with as an 1199 delegate, is that some of these conversations are so much bigger than any one site, any one union. These are like big fundamental holes in our labor policy as a country. Like pay equity, the way that we like flexible work hours for families. Um, there's a lot of conversations that are way bigger than just social work, just healthcare. It's like the way that we treat workers in this country are just awful. And there needs to be a lot of changes at the legislative level, on every level, like from the city to the federal level. There needs to be a lot of changes to improve quality of life for workers.
Thank you so much, Stephanie. And we have one more question in the panel portion, and then we will move into discussion for the remainder of the event. If you could get, this is for Debbie Feuerman, if you could get one concrete policy change, whether at the hospital, state, or federal level, that would most immediately improve conditions for social workers in healthcare, what would it be?
Yes, hi. Thank you so much for having me. This is such an excellent panel. Um, yeah, my name is Debbie. I'm a social worker for about 15 years. Right now, I work at Maimonides at the Community Mental Health Center. I provide outpatient psychotherapy for individuals and groups. And so something I've been thinking about for a long time, that would make such a immediate impact would be the New York Health Act. And I love the other things that were mentioned today about COLA increase, the temporary inflationary increase. And but also, I don't want us to neglect looking at the macro level and how that would really benefit social workers. So I wrote a couple of thoughts about it, just in case anyone hasn't heard of it. The NASW endorses it, and so does our union 1199 SEIU, which I'm so proud to be a member of and a delegate. So we just have to educate ourselves and do more action for it. The New York Health Act would provide quality health care for every New Yorker. So when I think about what we do, and in my experience, I've worked in different roles. I've done a lot of casework, and now as a therapist, I have 30 minutes or 45 minutes with a session with my patients, and I'm so lucky that I do long-term care. But I don't have a lot of time anymore for casework, and the health insurance problems. It affects everyone. We all know how broken the system is. So when I think about how much time and the moral injury that we get about hearing about all the problems with health insurance, we struggle with a system that's so broken, and it reminds me of like even Maslow's hierarchy of needs, something we like to, as social workers, like to think about. The first needs are the essential biological requirements like air, food, sleep, and healthcare is just obviously the most basic need. So I also think about this systems theory, which is very social worky concept, and it would obviously fix the healthcare system that impacts our patients' lives and our lives. And so, coming back to the fact that I'm in such a great union, right now we're getting ready for the next contract negotiations for the league contract, and right now our union is so focused right now on keeping our excellent health insurance benefits that we don't have as much capacity to negotiate for other things like increased wages or better working conditions. And so that I think would be, if we didn't have to worry, and individually each union in each hospital system to bargain for health insurance. If this would be essentially fixed with the New York Health Act. So again, that's something that I'm really proud that NASW and my union already endorses. And I looked up Assemblymember Hooks and Senator Prasad, that they co-sponsor it. And I really hope that we can continue to advocate for it and get it passed.
Thank you so much, Debbie. And yeah, we've been in coalition with the Physicians for a National Health Program, New York Metro chapter for some time now, and we really hope we can get that passed in this session. If not, in the next 5 years, we got to get this going. And so next we are going to go into our discussion portion of the event until 7:30. So Patrice, please feel free to unmute and begin our discussion.
Okay, so thank you about that. To Debbie's point, the last point that she made about the union focusing on meeting, maintaining our insurance, that is actually one of the talking points hospitals have used in many of our negotiations, is to address that. Oh, we give you so much in your benefits that justifies the need not to pay you an equitable salary. That's been the excuse for decades since I've been a social worker.
Exactly. Thank you so much for saying that, Patrice. Yeah, I hear the same thing.
So everyone, I saw the chat was blowing up for the last little bit of the event. So if anyone wants to unmute and share some thoughts with the group, please feel free to do so. This is an open space now, and I'll actually go ahead and stop the recording now just to allow everyone to have a comfortable space to express their opinion in the last 6 minutes of the event here.